Welcome to the program Addressing Negative Symptoms and Cognitive Impairment Associated with Schizophrenia, a focus on digital therapeutics. My name is Christoph Correll. I'm professor of psychiatry and molecular medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell in New York. And I'm also professor and chair of the Department of Child and Adolescent Psychiatry at the Charité University in Berlin, Germany.
And I'm Dan Fulford, associate professor at Boston University at Sargent College of Health and Rehabilitation Sciences and the Department of Psychological and Brain Sciences. I'm also the director of the Approach, Motivation, and Participation Lab at BU.
These are the learning objectives for today's program. 1. Recognize the burden and unmet needs in schizophrenia associated with the undermanagement of cognitive impairment and negative symptoms. 2. Differentiate the various symptom domains in schizophrenia with a focus toward the pathophysiology of cognitive impairment and negative symptoms. And 3. Assess how ongoing developments in clinical research in schizophrenia and digital therapeutics may help address current limitations in treating cognitive impairment and negative symptoms. Let's start with the first part, the burden of disease and unmet need associated with undermanagement of cognitive impairment and negative symptoms. Let's begin now with a case study. Let's meet Miguel. Miguel, he's a 48-year-old man diagnosed with schizoaffective disorder. He experienced severe auditory hallucinations and paranoia in the past, managed with antipsychotic, in this case risperidone 4 milligrams at bedtime. He has gained 25 pounds of weight over the years on different treatments, and his BMI is now 31, meaning he's obese. He feels sedated during the day, complaining of brain fog and feeling stiff. He struggles with motivation, which interferes with psychosocial functioning. His affect is subdued, and he reports enjoying very little anymore. Finally, he struggles with staying organized and planning activities, and has been out of work for years by now. So let's discuss what we've just seen here. What are your thoughts with regards to Miguel? So Dan, what symptoms are relevant in his presentation?
Yeah, so you mentioned brain fog, feeling sedated. Those could be related to medication, but could also be symptoms that we really want to focus on and assess more directly. You mentioned motivation. He's struggling with feeling motivated to get out and do the things he needs to do, and that's interfering with his ability to function. His affect is subdued, so that would be something we'd want to pay attention to. He's having trouble staying organized, and he's out of work, which may be related. So those are things I'd really try to assess a bit more of.
That's a great pointer here. So how would you assess this in more depth after he's brought up some of these symptoms?
Well, there are tools we can use. There are assessments that allow us to get into the details here. We may just use direct observation, or we may ask Miguel more questions to understand a bit more about what's driving some of those challenges, particularly around motivation, difficulties with being organized and getting to work or staying in a job. So I would really focus on what are the experiences Miguel is having, and what can we observe as well that sort of cohere with that. I might also ask questions of family members or other direct relatives that can give me some more information there that would be helpful.
So you might be interested what drives basically this lack of motivation. Is he sad? Is he just, does he have lack of energy, or what it might be? Is it the sedation? And are there any tools we could use in clinical care?
Well, the tools that I might use in clinical care could be basic screening tools that give me a little bit more information on how he's feeling. And so are some of those experiences related to low mood or depression? And so we might use something like a PHQ-9 or another screening for depression. For negative symptoms themselves, it's really difficult sometimes to distinguish between what might be depression, what might be due to more primary negative symptoms. So we'll try to ask as many questions as we can around how long-standing that's been. Is this something that's occurred more in direct relation to a mood change or things like that?
Right. And for cognition, it's also difficult to have a standard tool that's really usable in clinical care, correct?
Right. Exactly. Yes. That's a big challenge.
There are many clinical domains of schizophrenia that I think the audience is very familiar with. There are positive symptoms, things one wouldn't want to have, hallucinations, delusions, disorganized thought. But there are also negative symptoms, the absence of things that are relatively normal for human beings, like having affective range and gesticulation, being motivated, social, and also enjoying things. And there are cognitive symptoms which are quite ubiquitous, people having difficulties with remembering things, paying attention to them, being organized, and so forth. And we've already heard that Miguel has some of them. There are also mood symptoms, motor symptoms, and cardiometabolic burden that may all be part of the disorder itself, although each of those can be made worse by some medications. Cognitive and negative symptoms begin early and persist throughout the disease course. When you look back at people who had a first episode of schizophrenia, the first thing that seems to really go wrong is the problem with cognition. We then have an emergence of negative symptoms, very often actually during the prodromal phase before the psychotic symptoms emerge. Negative symptoms often stay the same or they might get worse over time, and cognition might worsen with some acute episodes, but again seems to be more a trait of the disease. Negative and cognitive symptoms are not only prevalent, but they're also relevant and in all phases of schizophrenia. Let me give you some pointers. More than 80% of patients with schizophrenia have cognitive impairment compared to the general population. And as we will see later, it's about 1 to 1.5 standard deviations below the norm. That's the cognitive composite functioning. Cognitive symptoms generally start before the first episode and are relatively stable in people with schizophrenia. More than 90% of patients with schizophrenia during the first episode of psychosis have at least one negative symptom. And about 3/4 of patients experience negative symptoms before the onset of the positive symptoms. More than half, up to 60% of stable outpatients with schizophrenia, again, have at least one negative symptom that can be quite impairing. And finally, 1/4 of patients experience persistent negative symptoms that last more than 12 months. When comparing different diseases that are either neurological or psychiatric and looking at the different domains of cognition, it is quite astounding that schizophrenia seems to be the most pan-cognitively impaired disease, while all of these disorders, including even Alzheimer's disease or Parkinson's disease, major depressive disorder, bipolar disorder, have cognitive impairment, they're either less severe or when they're severe, they're more limited to certain cognitive domains, whereas schizophrenia is quite severely impaired in almost all domains. So that was also the answer of your question that we asked in the beginning. Schizophrenia is the most cognitively impaired disease, and patients really struggle with their lives because of that. When looking at different cognitive domains and also the composite, it becomes clear that patients with schizophrenia are about 1 to 1.5 standard deviations impaired below the general population norm, and that explains quite a bit of their difficulties. The neurocognitive deficits also have profound impact on functioning. They worsen instrumental and problem-solving skills, skill acquisition, community functioning, work performance, and what we call recovery, which is a functional attainment in self-care, social interactions, leisure time, as well as work or education. When looking at negative symptoms, we can divide them into two different domains: the diminished expression, which is blunted affect and alogia, and the avolition apathy part, which is experiential, which also has anhedonia, asociality, and avolition. The experiential part is most likely more related to the functional disability. Let's go with the second section of these 3 chapters. Let's differentiate between cognitive impairment and negative symptoms in schizophrenia. Let's revisit Miguel. You remember he is 48 years old, diagnosed with schizoaffective disorder. He has paranoia in the past, managed with antipsychotics, in this case risperidone 4 milligrams. He gained weight. He feels sedated, he struggles with motivation, his affect is subdued, and he also can't stay organized. So now, what's your primary treatment goal? When you ask him, which you should always do when formulating goals for your patient, he wants to improve his organization in the hopes of finding a job. And he also feels that he needs to meet new people. I want friends, but it's hard to get out. So the question then is how we can help Miguel to reach his goals. When considering Miguel's problems and wanting to get more into detail, it's important to see how the cognitive disability might represent itself in the real world. You can't ask Miguel, do you have problems with attention and vigilance, working memory, or visual learning and memory? The right question would be, well, what about reading a book or pay attention to a movie? And if the patient tells you that basically he has to always go back to the beginning of the page because he's losing the content of where he started, that's a problem with attention. What about keeping a phone number in mind while dialing it, or having to always go back to the page? That's problems with working memory. What about going shopping without having a list of items and only bringing 3 out of 5 items home? That has something to do with verbal learning and memory, or not remembering where the key is that you put somewhere. That's all related to visual learning and memory. You may also ask, what happens when things do not go the same way? Like the bus schedule changed. Is that a problem shifting to a new routine? And also, what about touchscreen when somebody, for example, is working in a restaurant and has a hard time getting the order in time and people are always waiting and becoming somewhat restless? And then finally, maybe what makes us human the most is the social cognition. Can the patient anticipate what other people expect of them, what they feel, what might be the most appropriate action in a social interaction? Now let's discuss how to distinguish cognitive impairment and negative symptoms. Now, Dan, how would you actually differentiate negative and cognitive symptoms? Is that always easy?
This can actually be quite hard. This is one of the hardest things I find clinically. I think when you looking at negative versus cognitive symptoms, as you mentioned, you can't really ask a direct question about cognitive symptoms in particular. Are you struggling with planning or organization? Are you having attention difficulties? But you can ask for these examples in the real world. How do they impair this person in their daily life? Is it finding the bus route that is appropriate to get to the job? Is it where do I look for information online to understand my condition better? You can sort of query some of this to really get at what's happening in terms of cognitive challenges. You can also observe, absolutely. So observation is one important clinical tool for understanding difficulties in attention, working memory, other cognitive challenges. For negative symptoms, I think it's really critical to understand the extent to which this person desires or wants particular outcomes for themselves. And you mentioned with Miguel's case that he wants friends, he wants a job, he wants to stay organized in order to have the job. So I think those are really important ways to understand whether it's really reductions in motivation or drive versus planning and organization difficulties.
And that is basically the overlap and interaction, correct? If you don't have enough motivation, then it's hard to execute your cognition. So one is basically the performance and the other one is the capacity. So capacity is the cognition and performance is when you put it to action.
Absolutely.
So the questions that you might ask to differentiate the two?
Mm-hmm. So I would certainly ask about the extent to which these goals that Miguel has are important to them and really something that they feel that they need to have in their life that would really enrich their life. And so the extent to which Miguel can communicate those desires and wishes, I think, is a real reflection of whether this challenge that he's having is due to this reduction in interest, pleasure, drive, or more something that is really a cognitive impairment or something that gets in the way for his ability to organize and plan. So those questions are really rooted back into the extent to which these real world scenarios can reflect some of those challenges that they're having.
Yeah, and his affect being subdued, if he's depressed, then he might also have cognitive and motivational difficulties, and we can treat depression, which could be comorbid in someone with schizophrenia, so that would be important to rule out too.
Exactly, yes.
The differential diagnosis of primary and secondary negative and cognitive symptoms is crucial because first, let's do something by maybe modifying our treatments or modifying other things in people's lives so that they have an improvement of negative and cognitive symptoms. Because at the moment, it's hard to actually do something for primary negative and cognitive symptoms. We can grade these negative and cognitive symptoms that are secondary to something else in terms of different buckets. In blue, here you see these are psychiatric symptoms. In yellow, side effects of medications. In red color, you see physical conditions, and in gray, the environment. So when patients have depression, we need to treat that because that can give you pseudodementia or lack of motivation. Even anxiety and social anxiety can make you withdrawn and not go and mix with people. Substance misuse burns down the brain after a while so that people have no motivation to do things, and also cognition can be impaired. And hallucinations or paranoia can interfere with both cognition and also being social. But make sure that patients are below the neuroleptic threshold. We don't want extrapyramidal side effects that slow down the body and the brain. Sedation does the same, the brain fog that Miguel is talking about. Obesity can also lead to either sleep apnea, but also primary cognitive or secondary cognitive symptoms. Chronic pain can lead to reduction of social interaction, as can stigma or environmental deprivation. So, what has happened to Miguel? Basically, you know what happened to him in the past, and he wants to be more motivated. He is now switched to lumateperone. It could have been any of those switch drugs that all have less weight gain, sedation, and extrapyramidal side effects. In response, his positive symptoms remain under control. Over the next 6 months, he actually loses 14 pounds and his BMI drops below the obesity threshold of 30. He's now at 28. He does not feel sedated during the day anymore, and he has no complaint of any stiffness. However, despite that reduction of potential reasons for secondary cognitive and negative symptoms, he still struggles with motivation, which continues to interfere with psychosocial functioning. His affect is a bit brighter. He doesn't say he's depressed, but he still cannot foresee joy in things he used to do, and he does not do them because of that. He continues to struggle with staying organized all the way and planning his activities, and does not feel he could ever go back to any type of work if he stays like that. And he still wants to be more organized and motivated in the hopes of somehow becoming fit for a job again, not feel totally useless, and meet new people.
So each of these potential interventions can be effective for Miguel's residual cognitive and negative symptoms. Cognitive remediation in particular can help with these residual cognitive symptoms, and this is a well tried and true intervention for folks with psychosis. Social skills training can help clearly address social skills, but those can have secondary impacts on negative symptoms or other key outcomes for those with psychosis. Cognitive behavioral therapy has effectiveness, particularly for positive symptoms. There's not as much evidence for negative or cognitive symptoms, but that can be an option for some of those problems. And exercise can be very effective to both help with cognitive symptoms and negative symptoms. And so that's an emerging treatment area. And you asked what particular type. I think these high intensity exercise training can be very helpful.
So aerobic exercise, and for social cognition, even group exercise. But it may be hard when somebody has both cognitive and negative symptoms to motivate them to go out. But in a group, maybe other people can also draw them in.
Absolutely, yes. Yeah, group settings can be very effective for helping people stay motivated to return and adhere to treatment.
All right, now we're ready for the third chapter. Dr. Fulford, take us through the next chapter on digital therapeutics.
Great. Thank you, Dr. Correll. So today I'll discuss how ongoing developments in clinical research in schizophrenia and digital therapeutics may help address current limitations in treating the cognitive impairment and negative symptoms of schizophrenia. So in terms of psychopharmacological co-treatment with any antipsychotic in terms of its effects on cognitive impairment, except for a very small effect size with antidepressants and an NMDA receptor antagonist, no other augmentation strategy of antipsychotics was significantly superior to placebo for these cognitive symptoms in people with schizophrenia. Moreover, the quality of most of these meta-analyzed studies was generally low. In terms of current options for the treatment of negative and cognitive symptoms of schizophrenia, there are no current FDA-approved medications that specifically target these symptoms. In terms of psychosocial therapies, we have cognitive behavioral therapy, cognitive remediation training, social skills training, and family interventions. These can all be used in conjunction with antipsychotics. When it comes to things like cognitive behavioral therapy, they may address attitudes or behaviors associated with having symptoms. The most positive effects we see for cognitive impairment is with cognitive remediation training. Aerobic exercise can even help when it comes to negative symptoms and cognition. There's some emerging evidence there as well. There are also several pharmacotherapies in development for cognitive impairment. In schizophrenia, I won't go into all the details of these, but several are in either phase 1, phase 2, or phase 3 of clinical trials. And so there's a lot of emerging evidence here that we'll have to pay attention to. Another option for these symptoms is digital therapeutics. And digital therapeutics, briefly defined, include health software that is designed to treat or alleviate a disease, disorder, or condition by generating and delivering a medical intervention that has positive therapeutic impact on a patient's health. These are web-based programs, smartphone applications, and wearable devices that are designed to prevent, treat, or manage clinical conditions through software-driven, evidence-based intervention. They can be delivered as standalone, which would be in support with support of a clinician or by themselves, so a patient might use them on their own. Or they could be delivered in a hybrid format, which would include some sort of integration of provider or peer support with the digital therapeutic itself. And the key benefit of digital therapeutics is that they can provide accessible alternatives or supplement standard care for patients with mental health conditions. And this can include people with more serious mental health conditions like schizophrenia. Digital therapeutics can address current gaps in mental health care. They can reduce waiting times and extend the reach or accessibility of these interventions. They can provide anonymous support, which can reduce stigma and barriers to mental health care. And they can overcome even logistical barriers like transportation or time constraints that are associated with existing therapeutics. 90% of adults use and own a smartphone, and so that shows you that increased access can be at the palm of one's hand in terms of these psychosocial interventions that can be translated to digital therapeutics. So, Dr. Correll, what are your thoughts on the potential value of digital therapeutics in your clinical practice? Are your patients using any digital supports, wellness apps, activity trackers?
Yeah, I think patients do use these unproven apps that are in an app store and are wellness apps, but they often also drop them. I think nobody really knows which is a good one, which is not. Most of the apps that I see my patients using have to do with either sleep or activity, step count, but not much more than that, nothing that is really more specific. And I think even on the provider side, we really don't know what to offer, what to prescribe or use. Are there enough data behind it? So I think this is an emerging therapeutic area that has enormous promise, but it's also like a jungle, and I feel very ill-equipped and look forward to hearing more from you how to actually harness this technology.
Yeah, absolutely. You mentioned some things like wellness apps or these sorts of or off-the-market or trackers that your patients might have. Are you or your patients at all familiar with digital therapeutics specifically, which are designed to target some of these conditions directly?
I think patients are not, most clinicians are not. I'm a little bit more versed in the literature, what has recently been approved, but I also don't prescribe and use it yet. So I think we're in a nascent field.
Right, absolutely. So there are various positive outcomes associated with existing digital therapeutics for mental health. While this is an emerging field, we're generating quite a bit of evidence in the last 10 years or so. In particular, we see studies that show digital therapeutics can help decrease symptoms across a variety of mental health conditions, ADHD, anxiety, depression, trauma. There's a positive benefit on enhancing knowledge or psychoeducation around some conditions, including some evidence for increasing understanding of depression for patients. There's evidence of better medication adherence across attention deficit, mood, schizophrenia, substance use disorder. We have evidence that there are increased remission rates across depression and panic disorder. I think a key benefit potentially of digital therapeutics are the ability to improve functional outcomes, and there's some evidence emerging that in depression, panic disorder, and even psychosis, there's some improved functional outcomes. And I think ultimately, one of the benefits and promise of digital therapeutics is that we can reduce healthcare costs, and we have some evidence emerging in panic disorder and substance use disorder that is the case. Digital therapeutics commonly contain elements of cognitive behavioral therapies or other evidence-based psychosocial interventions. And part of the content there would include symptom monitoring, cognitive restructuring, which allows one to evaluate and change thoughts that may be maladaptive or interfere with functioning, Behavioral experiments, which are planned activities that help patients test thoughts or beliefs that may get in the way. Psychoeducation, as we discussed earlier, and things like skills training, social skills training in particular. Very exciting development is that Medicare is proposing codes that will allow physicians to bill for FDA-cleared digital mental health treatment devices that would be used in association with other ongoing treatments, and that would be starting as early as 2025. When we think in particular of prescription digital therapeutics, we have to look at the larger landscape of digital health technologies, which would be anything that can involve industry or administration-facing health technologies. This could be software for medical records, other operational software that can help with health information technology. These could be healthcare provider facing, so clinical software with digital health solutions that are really facing for the clinician themselves, help them in their care of their patients. Or they could be patient facing, which we talked about a little bit before, health and wellness apps, other patient monitoring, remote monitoring devices. Digital therapeutics, as we discussed before, are more specific to treating a particular condition. In the case of mental health, particular psychological or psychiatric disorders. And these are software that is designed to prevent, treat, or manage a condition or illness. In the smallest bubble here on this slide are prescription digital therapeutics. So these would, as you might imagine, be digital therapeutics, but that require a prescription to be used in the context of medical care. So in addition to requiring a prescription, there are several elements of prescription digital therapeutics. They receive labeled claims by health authorities. Their clearance and indication are based on results from randomized clinical trials. They're developed under good manufacturing practice, so that's rigorous evaluation for safety and effectiveness. And the idea here is that they'd be reimbursable by health insurance companies and regional health systems. As of 2024, at least 8 prescription digital therapeutics for psychiatric and substance use disorders have been cleared by the FDA. The FDA clearance process involves undergoing randomized controlled trials to demonstrate safety and efficacy. The data from these trials are submitted to the FDA as formal requests of software as medical devices, and that's through 2 different potential pathways. The de novo pathway, which requires clinical data that demonstrates the safety and effectiveness of the device, and also the 510K pathway, which requires submission of clinical data that shows substantial equivalence to other devices and demonstrating safety and effectiveness. The software may be frequently updated following FDA clearance, and that's a sort of a difference between software as medical device in the digital therapeutic space and say, a drug, because a technology is constantly evolving and changing, and so we need more flexibility when it comes to FDA clearance. And there's a dedicated regulatory framework for software as medical devices that is always in flux, is always evolving. So here's a list of FDA-cleared digital therapeutics for mental health. There are a variety that address ADHD, traumatic disorders, mood disorders. But as you can see on this list, there's nothing so far that is designed to directly address negative symptoms or cognitive impairment in schizophrenia. So the answer to the poll is none. There are prescription digital therapeutics in development for schizophrenia. One is PAIR-004. In their initial trial, they investigated the app in comparison to a sham app. Assessments were done at 4, 8, 12 weeks. They had a final follow-up after 16 weeks, and the primary outcome was positive and negative symptoms as part of the PANSS scale. This digital therapeutic delivered cognitive restructuring, self-management, and social skills training. While there was some promise in terms of safety, both groups demonstrated small benefits to positive symptoms, meaning decreases in positive symptoms after 12 weeks, but there was no added benefit of PAIR over the sham app. This lack of differential group treatment response was attributed to potential unanticipated benefits of the sham control condition. It could have distracted patients from their positive symptoms, which would have benefited both groups. It's also possible that patients benefited less from the intervention than they could due to limited understanding or limited active engagement with intervention content. Another prescription digital therapeutic in development for schizophrenia is CT155. CT155 is currently being evaluated in terms of its acceptability and feasibility in one trial. In another trial, there are outcomes associated with engagement with app usage. And so far, results are promising in terms of the feasibility and efficacy for negative symptoms in particular. And importantly, as part of CT155, patient feedback is really critical to the development and refinement of the intervention itself. So going back to our case study of Miguel, while his positive symptoms were well managed, Miguel continued to feel unmotivated. He wanted to meet new people and seek employment, but just didn't feel like he had the drive to do so. His psychiatrist learned of a digital therapeutic that was designed to address negative symptoms, including low motivation, anhedonia, or lack of interest or pleasure. And she reviewed through a website that was dedicated to highlighting various digital therapeutics for clinical conditions. Her colleague, another psychiatrist, had used the digital therapeutic for his patient who was struggling with chronic insomnia. And he recommended this site, walking her through the basic features of these digital therapeutics. She discussed the app with Miguel, her patient, helped him download it on his phone, and walked him through registering and setting up some treatment goals, which they plan to check in with each other on at their next appointment. Over the next month, Miguel started to make progress in his social and occupational goals, including he met a couple people online, put together a resume to apply for some jobs. But about 6 weeks into using the digital therapeutic, Miguel was less engaged with the app, and him and his psychiatrist attributed that to changes in his mood. They agreed to review digital therapeutic content together at the beginning of each session and focused on using the pleasant activities feature each day, which helped improve Miguel's mood and reinforce use of the app together. After a couple months of using the digital therapeutic, Miguel felt more motivated, starting enjoying more of his activities, was making more progress on his personal goals. And given this success, Miguel's psychiatrist started using more digital therapeutics with her patients, including one who had panic disorder and another with alcohol use disorder. So in summary, negative and cognitive symptoms are a reality for most people living with schizophrenia and have high clinical relevance for both their caregivers and healthcare providers. Due to the impact on functional outcomes, negative and cognitive symptoms require clinical attention. Currently, there are no approved treatments for negative and cognitive symptoms, but several pharmacological and digital treatments are being investigated. Digital therapeutics include software designed to prevent, treat, or manage a disease or condition, and prescription digital therapeutics in particular receive label claims by health authorities, are developed under good manufacturing practice, are rigorously evaluated for their safety and effectiveness, and may be eligible for reimbursement by insurance companies. In terms of practical takeaways for today's discussion, assess your patients for negative symptoms and cognitive impairment and the impact they have on their quality of life. This is critical for the effective care of your patients. Help patients manage negative symptoms and cognitive impairment with psychosocial therapies. And consider using digital therapeutics and, when available, prescription digital therapeutics with your patients as an adjunct to existing treatment and an additional option to support symptom management and psychosocial functioning.